Introduce yourself. Hello, everyone. Good morning. Okay, it's still morning. My name is Fola Koladefe. I'm a GLODERM mentee alumni. I'm meant to be chairing this session. So we're just waiting for everyone to get settled in so we can start. We're a bit behind time, but no pressure. Thank you. All right, so thank you everyone. Once again, I'm Fola Kemi, or Fola for short, a dermatologist from Lagos, Nigeria, and I'm going to be chairing this second session, which is Advancing Global Skin Equity, Skin Health Equity. So we have three amazing speakers, but I understand one of the speakers needs to leave a little bit earlier, so we're going to call him up first. And so we're going to start with Dr. Dallas Smith, I believe, yes. He's going to be taking a presentation on tackling implantation mycoses, challenges, awareness, and global multidisciplinary action. So I'll just talk about Dr. Dallas Smith and introduce him. He's an epidemiologist in the Mycotic Diseases branch of the U.S. Centers for Disease Control and Prevention. And Dr. Dallas Smith is an epidemiologist / pharmacist. That's an amazing combo with the Mycotic Diseases branch at the U.S. Centers for Disease Control and Prevention. Prior to coming to the CDC, he has served as a Peace Corps volunteer in Cambodia from 2017 to 2019 and Malawi in 2019 to 2020. Dr. Smith serves as the subject matter expert for fungal neglected tropical diseases and molds, and leads the branch's antifungal stewardship activities. So it's a pleasure to welcome you, Dr. Dallas Smith. Thank you.
Hi, everyone. So I am one of the fun guys and fun gals at the CDC. I'll try to keep the puns to a minimum, but we really like them. So I'm going to talk to you all today a little bit about implantation mycoses. I'm going to start with a challenge and then some recent efforts to kind of address these, which really aligns with a lot of the priorities Claire mentioned in her first talk today. But I want to frame implantation mycoses around fungal NTDs because a lot of them are included as fungal NTDs. And to begin with, I'm probably biased, but I do think the fungal NTDs are the most neglected of the NTDs. I think many people don't even realize there are fungi on the WHO list, but there are some. And so in 2016, mycetoma was added to the WHO fungal NTD list. In 2017, chromoblastomycosis was added, and also this phrase afterwards, and other deep mycoses. Unfortunately, at that time, no one defined what that meant, and so we have been working with WHO to kind of define that, and that has come to be sporotrichosis and paracoccidiomycosis. I'm going to focus more on mycetoma, chromoblastomycosis, and sporotrichosis today because these are true implantation mycoses. Paracoccidiomycosis, which is endemic really only to South and Central America, is more of an inhalation fungal disease, a pulmonary fungal disease. But these three fungal diseases are usually acquired after a break in the skin that allows a causative agent to enter, which is why we call the implantation mycosis. You implant them into the skin. They are more common in tropical and subtropical areas, but they can be acquired everywhere. We actually just investigated a case of locally acquired chromoblastomycosis in a pediatric patient in Texas who was swinging on their swing and got Fonseca infection. So they can be acquired everywhere, which I think is a good advocacy tool for a lot of us, that these are really horrible infections. They affect poor communities typically, especially those without access to health care. They occur in rural areas where there is limited infrastructure to diagnose, and of course, what we've been talking about all day, limited therapeutic options as well. They are classified as skin NTDs, and that's one of our approaches to be able to better integrate these neglected NTDs and neglected fungal diseases into more broader programs. Global funding is very minimal for NTDs in general, but it gets very sparse for fungal NTDs. And so this global funding report by GFinder, which I think many of us are familiar with, it highlighted that mycetoma receives less than $1 million a year in R&D. Chromoblastomycosis and sporoticosis aren't even mentioned because there is no investment. The 2025 update of the NTD roadmap by the World Health Organization really noted little progress with these 3 fungal NTDs. Only 1 country reported mycetoma or chromoblastomycosis in 2023. None reported sporoticosis. And unfortunately, the only country that really reported mycetoma at high levels, Sudan, is ongoing a horrible civil war, and so they did not even report data in 2024. Access to diagnostics, and appropriate treatment is very limited for fungal NTDs globally. This was a really nice survey that was done by the World Health Organization just a couple years ago, looking at implantation, diagnostic, and treatment. You can see from here that maybe the percentages don't actually look as low as you would think, but I want to point out the footnote down here that 52 of the respondents were from upper middle income or high income countries. And you can still see that these diagnostics were limited, which is really unfortunate because you don't need really advanced technology to diagnose fungal NTDs. Sometimes you just need a microscope. When transitioning to treatment, there has been some estimates that 78 million people have no access to itraconazole globally. This does not even account for those in country that has the drug but cannot afford it. So you can imagine that number increases substantially. It's a lot of inaccess to a very old generic antifungal that can treat all of the implantation mycoses. And some implantation mycoses, unfortunately, are so neglected they're not even on the NTD list. So I'm going to introduce 2 of them today. One of them is lobomycosis, which is what we think is only endemic in South America and Central America. However, we have seen a few cases pop up randomly globally, and so we don't know really what that means. But this is a horrible disfiguring skin infection. It causes physical disability. You can imagine from these pictures, it causes a high amount of stigma in communities and among patients. And of course, all of this leads to significant decreased quality of life. The other one that I want to mention is I can't even pronounce this one very likely, and I'm a fun guy. But the entomomorphosis, which causes these chronic destructive lesions, and this is really globally distributed. It's probably very highly underdiagnosed. It's probably more common than what we think. There's maybe these 2 causative genera fungi, not important, but you can just see the destruction that this implantation mycosis causes, and I bet many of us in the room have never heard of it. All right, so that's the problem. That's the challenge. Let's talk about awareness and some global multidisciplinary action that's been happening over the last few years. So the first thing that I want to mention that many of you in this room are already involved in, and if you're not, I encourage you all to get involved with, is that we have these global working groups for chromoblastomycosis, mycetoma, and sporoticosis. And so anybody's welcome to join. We have clinicians, policymakers, researchers, basic lab scientists, students. Anybody that's interested, there's plenty of work to do with these implantation mycoses, and so really encourage you all to join if you're interested. The other thing I want to mention is that AMR, antimicrobial resistance, gets a lot of funding, a lot of notoriety, a lot of advocacy, and so we're trying to think through how do these fungal NTDs play into AMR. And what we've been able to do, especially for chromoblastomycosis, is establish these tools to monitor for antifungal resistance. I won't go too in depth about the tools, but they're called epidemiological cutoff values. They're not breakpoints, but they do allow you to monitor for antifungal resistance, and we have started seeing resistance because we're looking for it now. And so when we think about, well, how can we integrate into other platforms, we're talking about common skin diseases, talking about malaria programs, but what about AMR programs? I think there are, even beyond fungal NTDs, ways we can integrate into broader AMR that has a lot of funding and a lot of advocacy around it. And this consortium has 13 labs from 8 countries. And so not only are we developing these tools, but we're building capacity in countries where these diseases occur more often. One of the things that I think, I'm glad I put this in my presentation that was really highlighted in Claire's presentation earlier today was how can we leverage existing infrastructure on the ground. And so we collaborated, really our colleagues in Indonesia really did most of this work, all of this work, and we just supported virtually. But what they did was they leveraged malaria microscopy infrastructure. And so in rural parts of Indonesia, there's microscopes on the ground for malaria diagnosis. For those who aren't familiar with chromoblastomycosis diagnosis, all you need is a microscope and some potassium hydroxide. And so what they did was they cross-trained these frontline healthcare workers who were diagnosing malaria all the time on chromoblastomycosis microscopy. They diagnosed 10 cases within a year on the small rural island of Sumba. And so this is a really great example of, this is a low-cost intervention. Really the only thing that needed was the cross-training. And there's some virtual teledermatology support to confirm the diagnosis and also for management. And so I really want to highlight that this work is already being done for fungal NTDs. How can we scale this up? This is a really great intervention from our colleagues in Indonesia. I also want to mention, so transitioning from chromo to mycetoma, there was a world's first mycetoma clinical trial, which is kind of crazy to say. It's pretty astonishing. That was done in Sudan, supported by the Drugs for Neglected Disease Initiative, and run through the Mycetoma Research Center before the civil war in Sudan. And what they did was they compared a new azole, fosufurconazole, which is dosed once weekly, to itraconazole. We were expecting to see fosufurconazole to perform really high, like have extreme efficacy benefits over itraconazole. But what we saw was that the cure rates for itraconazole were 75%. And past reports were as low as 20%. Fosufurconazole had very similar cure rates, and so there was a non-inferiority study, and so they were non-inferior to each other. And we were starting to think about, like, we already have the tools to care for patients from mycetoma. We need to focus on early diagnosis and access to itraconazole. And so we don't need these new crazy interventions. We just need these tools to be deployed appropriately to frontline healthcare workers. They cannot be in these decentralized areas where patients wait years and years and years, where the infection is so hard to treat that the only option is amputation. And so this is a really great, of course the clinical trial is amazing itself, but the results are really promising that we already have interventions that we can use. I also want to mention, and I'm glad Claire mentioned this earlier, is that the true burden of disease, lots of times we stop at case counts, maybe mortality. A lot of our fungal NTDs, they're not going to lead to death, although they can. But what about the true burden of disease beyond case counts? And so what we were able to do with DNDI, the Drugs for Neglected Disease Initiative, in Turkana, Kenya, which actually Cindy, we kind of partner on, our other Kenyan colleagues who gave a presentation earlier today, we were able to conduct the first ever social behavioral study in Kenya that was able to quantify and qualify some of the true burden of disease, the stigma, the disability, the quality of life problems. And it's a really interesting study that goes just beyond this case counts. This is a really great advocacy tool because you go to policymakers and you say, we have 30 cases of mycetoma in Turkana, Kenya, and they're like, so what? But if we can say 3 of those patients had amputation, 15 of them lost their job, 30 of them had loss of income over a year, that's powerful, very, very powerful. The other thing I wanted to mention is that there is a new species of sporotrichosis spreading in South America, really heavily in Brazil, called Sporotrix brasiliensis. It spreads zoonotically, and there are thousands and thousands of cases in cats and humans, and it just keeps spreading. It's spread all across South America. We have seen cases in the UK from an imported cat from Brazil. But what's really cool is that oftentimes we cannot determine how common a disease in a country if it's not reportable. Just last year, we were able to work with the Brazil Ministry of Health to make sporotrichosis a reportable condition. So we're actually getting real-time data on the amount of cases that's occurring, which is, of course, is another great advocacy tool just to show just the true burden, at least from a case count perspective, that can lead to future studies and future interventions. I don't want to forget about our neglected non-NTDs. And so we are also tracking the detection of local mycosis in new areas of Brazil. Historically, we thought it was limited to this Amazon basin area, but we have seen it outside of that area now in Brazil. We're not sure what it means, but at least we can raise awareness among healthcare providers to keep it on their differential, which is really, really important as we better understand the environmental niche of it. I also want to mention, which I think Claire and I were just talking about, trainings for frontline healthcare workers, for dermatologists, for anybody who are interested in these fungal NTDs where they're probably neglected in curriculum. I never learned about them in pharmacy school. I'm sure many of you have maybe got an hour, if you're lucky, on these diseases. And so what CDC has done is we created a free online interactive training on fungal NTDs covering chromo, sporo, and mycetoma. For those who are based in the United States, there is CME associated with it. And so we really encourage you to check this out, but I think we're going to work with Claire to get it on the IDLS platform, which I think is going to be a really good resource going forward. We're also having it translated in Spanish, French, and Arabic going forward, and Portuguese. I wanted to keep it with time limit. I, unfortunately, have a wedding to catch. I have to pick up my family in Atlanta before going up to DC. But Carrie mentioned I could take some questions, but I apologize for not staying longer. You all are incredible, so I'm very sad to be leaving so soon. But happy to take any questions, and thanks again to Carrie for the invitation and the GLODERM community.
Okay, so if we have any questions for Dr. Dallas-Smith, thank you so much. Yes, Dr. Yes.
Thank you, that's absolutely brilliant. As we'd expect from the mighty CDC, that was absolutely brilliant. And you're so smart. It's great to see you. No, that's a backstory that I'll tell you all about later. Just wanted to say that your reference to cross-cutting issues, I think that is our greatest strength. And I'm just kind of, it's a call to all of us. How many articles can we get out there which are, can we use cross-cutting issues? Where can we repurpose old technologies to benefit getting skin diagnoses out there? And I just wonder whether that's a kind of call to action. Just really, really some great thoughts. I'm writing some notes. Anyway, questions?
Thank you so much. That was fantastic. I'm Wingfield Remus from Canada. And I'm curious, in that study with the itraconazole and the rates were so much higher, why? Is it because people didn't take the full course, whereas in the clinical had not had access before? Presumably in the 20% they had gotten drug as opposed to never having gotten it.
Yep. I think two things. I think one, access. In Sudan, itraconazole was relatively available, but not for a full year. For those who are unaware, you need to treat mycetoma for at least a year. So imagine taking itraconazole twice a day for a year. One, it's hard. Two, it's expensive. So I think because we were able to get consistent access, that was huge. The other thing that I probably should have highlighted a bit more was that they included patients with early disease. And so that means they engage community health workers to get out in communities, detect it early, get drug on early, consistently, and the cure rates are 75%. I mean, it's incredible. With itraconazole, we had no idea that was going to be the case. So I think it's twofold: early diagnosis and consistent access over a year.
I have a question also. I am from Egypt. Although it's not relevant to your talk. Now we know that trichophyton endothenia is going all over the world, in Egypt, in the United States, and everywhere. And you know as well that sometimes this trichophyton go deep in the skin. In our country, we do have itraconazole. It's not expensive. But people may use it for 2 weeks. Maybe if the doctor, he know what about it, as like India, they use it for 2 months, 3 months. What we are going to do, or the WHO, what is going to do?
Yeah, and trichophyton endotheniae is one of our biggest issues right now in the United States and globally. I'm assuming a lot of the dermatologists in this year is either really concerned about it or have been treating cases. I'm going to call Avram Kaplan in the back over here, who is the expert in the United States for treating T. endoteniae. But I think we need better data to figure out how long we need to treat these patients. What drugs work? Oh, is itraconazole the only option? Are there some better topical treatments like efinaconazole? Expensive, but it looks great in vitro. We need better data to inform treatment for T. endoteniae. And that will probably require randomized control trials going forward, which I know are difficult. But because we're seeing so much of it, I think there's an opportunity to really learn how to properly treat this medication, or this resistant dermatophytes.
There have been a report in the Blue Journal about that. For how long we can use it and the concentration. And in a country like Egypt, you are going to find usually the problem is all over the body. Right. And so topical are not going to work.
Right. You mean for the deep when it goes deep, right?
No, I mean the superficial, even,
right.
Not the deep.
Right.
Still, I never saw a case going deep, but I saw it in another patient long ago, not trichophyton endothenia.
For other trichophyton species, yeah. I think we just need to, I think dermatophytes have been neglected for so long that I don't think we really understand them completely in terms of the best way to treat them and things like that. So I think there's going to be more research and more advocacy. The other problem with dermatophytes is that we often don't diagnose them. We just look at them clinically, and we often get it confused with non-infectious and infectious etiologies. A lot of us love this, not a lot of us. I think the people in this room do not love it, but those nice combination creams of antifungals and high-dose corticosteroids. And so I think we need to think through how this applies to a stewardship perspective too, how we better use these steroids topically. I think it's going to be a big thing going forward.
Thank you so much for that very powerful speech and lecture. I think, we do see mycetoma even in Nigeria. I think there's not enough data or reports of it. And so it's great to see that early detection and also the tools that we already have are, we just need to use them a lot more, especially with microscopy and diagnosis. Thank you once again, Dr. Smith, and wish you a safe journey. Bye. Okay, so I think we can go to the next presentation, and we want to talk about, it's Professor Furen Zhang, and I really like the title of this presentation. It says, Finding the Needle in a Haystack, Best Practices for Skin NTDs Control in Low Epidemic Areas from Shandong Province in China. So Professor Furen Zhang is a dermatologist and researcher based at the Shandong Provincial Institute of Dermatology and Venereology in China. He is renowned for his extensive work in leprosy, psoriasis treatment, and genetic studies of skin diseases. He has contributed to developing effective strategies for early detection and targeted intervention, helping improve public health outcomes in undeserved populations. It's our pleasure to welcome Professor Zhang to the podium. Thank you.
Good morning, everyone. The topic I would like to share with you is found the needle in haystack, best practice for skin NTDs control in low endemic areas from Shandong Province, China. Skin NTD used to be a heavy public health burden in China. After 50 years campaign, skin NTD is not a big problem. But there are still some cases emerged annually. So how to find the skin NTD cases at the early stage is a big problem. So this is my story to share with you. The outline including this four part. First of all, I would like to introduce the the situation of Shandong Province. Shandong Province in the east part of China, you can take a look, the yellow area, and the province has a total area of 150,000 square kilometers with a population of over 100 million. Shandong used to be one of the most leprosy endemic provinces in China. So far, it registered 50,000 leprosy cases since 1950s. The cases, most of the cases were detected during 1950 to 1985 through active case finding activities that including population survey, contact examination, and a repeat village survey. This campaign usually took place in 1960s, 1950s, 1980s. And with the introduction of multi-drug therapy recommended by the WHO from 1986, the leprosy cases or the prevalence of leprosy declined dramatically. At the turn of the new century, leprosy has been eliminated according to WHO criteria. That it means which means the prevalence below 1 per 100,000 and the incidence rate below 0.1 per 100,000 in 1996 in China. So at that time, only few cases detected annually. Last year, we have only 4 new cases of leprosy, but all of the cases were diagnosed at a very early stage. I will show you next. So you can take a look of the 2 maps. In 1950s, we have 280,000 leprosy cases, but at the turn of this century, there are only 2,000 leprosy cases, the whole country. So after the elimination of leprosy, there are still some problems exist. First problem is the number of new cases keep unchanged from the year 2000 from the year 2000 and to the year 2010. Annually, there are about 200,000 new cases globally, and also 2,000 cases in China. You can take the picture. This is because no effective vaccine for leprosy. The WHO recommend chemoprophylaxis for all the close contact. This is difficult to carry out. For example, if I am a leprosy case, I have close contact with all of the audience. The audience should take the rifampin for chemoprophylaxis. So it is very difficult to carry out this schedule. And the epidemiological survey shows that only 1% of the close contact of the close contact will develop to be a leprosy cases in 10 years. So in order to prevent 1% of the patient from occurring leprosy, 99% should take chemoprophylaxis. So it is unrealistic. So the second problem is the G2D rate is very high because we have declared that leprosy has been eliminated. So both healthcare workers and the public losing awareness for leprosy. The institutions of leprosy control at all levels in China are merged with CDC or hospitals. And also, pathogenic diagnosis for paucibacillary leprosy is lacking. For in the early stage of PB, patient, it is difficult to do a right diagnosis. For at the early stage, no loss of sensation, no enlargement of peripheral nerves, and also the smear is negative. So it is very difficult to do an early diagnosis, which will result of the high rate of disability. So you can take a look of this picture from the year 2000 to the year 2010. The G2D rate of leprosy is as high as 30%. The third problem is the second harm of leprosy, DHS, that had never gone away. Dapsone had been used for the leprosy treatment since the 1950s. It cured thousands and thousands of patients, but it also results of the deadly side effects we call Dapsone hypersensitivity syndrome. The death rate as high as 10%. Can we overcome this second harm? So in the year 2011, the Ministry of Health of China issued a campaign. That campaign lasted from the year 2011 to 2020. That is the political commitment by the government to eliminate the leprosy harm. In the 1980s, Chinese government also issued a campaign that eliminates leprosy. But in the year 2010, we issued another campaign that eliminates the harm of leprosy. From a scientific point of view, leprosy can't be eradicated in the near future. We have a long way to go, but we can eliminate the harm of leprosy. So the technical solution to the problem, the primary prevention, the research breakthrough and translation, we can do the precision chemical prophylaxis and find the risk layer of DHS to screen high-risk individuals so that we can do the precision prophylaxis. Second prevention is develop new technique for the early diagnosis of PB. And the third, deliver the technical portfolio. We integrating the vertical system with the horizontal institutions to the whole population. The first, primary prevention, the research breakthrough and translation. In the past 20 years, our team carried out serious research. We found a serious leprosy risk allele. We construct the disease prediction model based on these risk alleles, and we can confirm the high-risk individuals of close contact and give these high-risk individuals the chemoprophylaxis. And also, my colleagues in the National Center in Nanjing, Dr. Wang Hongsheng, their team have carried out another campaign. They use single-dose rifapentine in household contact of patients with leprosy. They found that it can prevent as high as 90% of the high-risk individuals to develop into leprosy cases. And also, we found the Dapsone hypersensitivity individuals carry the allele of HLA-B1301. The individuals who do not have this allele will not take place Dapsone hypersensitive syndrome. And we implement a screening campaign to all the patients. Before the patient takes Dapsone, we do the screening test. If the patient do not have the allele, we use MDT. Otherwise, we use alternative therapy. Thus, Dapsone hypersensitivity syndrome have been eliminated in China. And secondary prevention, we developed a new technique for the early diagnosis of PB. And then we raise the awareness of the public we told our audience that leprosy still exists in Shandong Province in China, and sometimes can delivered from the outside, and training healthcare providers at all levels. The strategies established of molecular diagnostic technology and public education. Every year we use the leprosy day and raising the national awareness and knowledge and calling attention leprosy can be prevented, treated, and cured. This person is our Shandong provincial governor. The vice governor attend these activities annually, and he visit leprosy old village, and also to the public. And we held a lot of training courses. We training healthcare providers. Every year we conduct 4 training courses for local doctors from 16 cities of Shandong Province. More than 500 doctors attend training programs annually. And the detection diagnosis method of leprosy were taught in the courses. The third, we reshape leprosy control system. In 1950s, leprosy is a big public health burden. At that time, the Chinese government set up a network from national level, provincial level, municipal level, and county level, the specific institutions for leprosy control. After 70 years campaign, the leprosy has been eliminated. So today, we still keep these institutions, and also by integrating water system with the horizontal institutions to the whole population. You can take a look of this picture from provincial level, municipal level, prefecture level, and also from the horizontal point of view to the Department of Dermatology of the general hospital. Thus, we constitute a new network. If a skin disease patient cannot be diagnosed at the early stage, then the patient will be referred to the provincial institution or municipal institution. And also, we set up a multidisciplinary team in referral center. You can see the patient just have a lesion on his back. This patient visit my clinic. We do a punch to do a pathological examination. We found the granuloma. Then we do the PCR. We confirmed it is caused by mycobacterial lepra. So at the same year, the patient was cured only in half a year. So today, the disfiguring disability has gone. All of the leprosy patient, just as the common skin disease, no stigma, no discrimination, because the disfiguring and disability have been eliminated. So the rate of G2 disability declined to 0. And in the past 5 years, we carried out some international collaboration and training toward the leprosy-free world. This scientific conference of leprosy held by our team in the year 2017 in Singapore, in the year 2019 in Indonesia. And also we have collaboration with the Indonesia teams to do the validation study of HRAB1301 as a biomarker of Debson hypersensitivity syndrome. And also we carried out international training and collaboration courses, the first, second, and third. This year's international training program will be held at September 7 and 18. And another 3 stories I would like to share with you. Another Skin NTD service. The Skin NTD not only include leprosy, but also include mycobacterium murine, and just as the mentioned, chromoplasma mycoses, sporotrichosis, and so on. So in the year 2019, an outbreak of mycobacterium murine infection associated with handling SARS, a kind of fish, broke out in Shandong Province. You can see reporting the index patients with the hand with the lesion, and we found that a total of 215 patients were involved. And all of the patients, when they handle the fish, his or her hand were stamped by the fish bone. The fish was contaminated by a mycobacteria. And this is the characterization of sea bars. And this is the food culture difference, makes local outbreak of mycobacterial infection. The Chinese food culture, they want to get the whole fish to cook in the chicken. But in Westerners, they do not. In the 1950s, there are diseases called swimming pool granuloma or fish tank granuloma. These NTD have been eliminated in Western societies, but in China, it's another type. It emerged. The second story is the annual outbreak of sporotrichosis. Also, this is the kitchen worker. His finger have some lesions. So I suppose it's contaminated by the mycobacterium murine, but it's no effective when we use antibiotics. After the field investigation, we found the worker to type of the crabs with the cotton ropes, and the cotton rope was contaminated by sporotrichosis. This is the field investigation and the finding. A total of 6 restaurant employees with similar lesions were identified. And all of them, the pathogenic examination confirmed the diagnosis. The histopathology demonstrated the epidermal hypoplasia and the dermal granulomatous with PAS positive, yeast-like structure. And the culture confirmed it's Sporothrax, sporotrichosis. And then the patient have been killed. And also the third story is a case of mycobacterial chalanes infection caused by cosmetic injection. So the lady wants to be, she was young with some injections. The needle have been contaminated. Then some lesions appeared on her face. And also we confirmed it's a mycobacteria chalanes. These 4 cases. And let's have a little summary. Leprosy is still a problem in China. Although it is not a heavy burden for public health, in order to eliminate the harm of leprosy is sustainable, we have a long way to go. We are willing to share our experience of leprosy control with our international colleagues to create a leprosy-free world. With the declining of leprosy cases worldwide, the prevalence of other skin NTDs is increasing, such as skin NTM, fungi infection, scabies. Only multidisciplinary team, including dermatologists involved, can we eliminate the harm of skin NTD. This is my team. All of them are very young. And I acknowledge the international collaborators. Thank you for your attention.
Thank you very much, Prof. Okay. Thank you very much. That was a fantastic presentation, laying the framework for leprosy control where some progress has been made. Because sometimes when there's progress, we kind of rest on our oars and then it comes back. So this is kind of like, we hope we can follow in your footsteps in the near future when we make more progress with leprosy control in other parts of the world. Thank you very much. And so we're going to go to the final presentation. Dr. Dr. Esther Freeman is going to be talking about the Lancet Commission, a new agenda for global skin health. So, Dr. Esther Freeman is the director of the Global Health Dermatology at Massachusetts General Hospital, Harvard Medical School. She serves as the Director of Clinical Innovation and Education for the Center for Global Health at the Massachusetts General Hospital. As founding and immediate past chair of GLODERM, yay! She is the vice chair of the International Foundation of Dermatology. We are really, really happy that she's here, and she's also an epidemiologist focusing on underserved communities. So we're really excited to hear about the new agenda for global skin health with the Lancet Commission. Thank you very much.
Thank you, Fola. I'm going to make Fola stand up. We're going to do this really quickly. So we have a GLODERM tradition of when we're kind of towards the end of doing a little stretch so we all kind of feel invigorated. And because we're running behind and I don't want Carrie to lose her mind, instead of spelling the full word coconut, we're just going to spell cocoa. All right, so please stand up, and Fola's going to help me. This is a GLODERM tradition. So for those of you who haven't done it, we are going to use our bodies. We normally spell coconut, but we're out of time. So we're just going to spell cocoa. So Fola's going to lead us here.
Yep. Okay, so just a quick stretch, so that we don't get stiff and all. So just to create C with your body, you can move to whichever side you prefer. C and then O together. Good, and then another C and another O. And we can just shake it off a bit. Yeah, so we're up a bit, so go ahead.
All right, thank you. As you can imagine, what the N is actually the hardest part, so we saved you. Yeah, it involves bending over and kind of being an N. It's very complicated, yeah. So next time we'll make you do the full coconut. All right, fantastic. I wanted to share with you an exciting development, which is the concept of a Lancet Commission. And what I want to share with you today is the fact that we are launching the first ever Lancet Commission on skin health. Oh, and I think we're frozen again. To our wonderful, what did he do? All right, so I will keep talking while we figure this out, since we're short on time. So the Lancet Commission, for those of you who are unfamiliar with the concept of a Lancet Commission, is run by the Lancet, which is an internationally renowned journal in medicine, and they have focal areas where they call out particular topics. Historically, these have been anything from Lancet Commission on obesity, Lancet Commission around climate change, but I can say of the last 100 Lancet Commissions, Lancet Commission on global surgery, for example, there have been exactly 0 on skin disease. And so it's not for lack of trying, but it's really wonderful that we have now finally made progress and are kicking this off. Thank you. Great. So what I wanted to share, and this audience knows this already, that we know that we are a major cause of disability and so many people affected worldwide, and that we know that skin disease is far beyond just the visible and includes things like stigma and its effect on people's work and effect on people's lives. So I think we've heard wonderfully explained today, whether it was from Kenya, whether it was from Australia, whether it was from China, about the issues around access to dermatologic care. And we know that in many countries, for example, including in China that we just heard about, that there is an epidemiologic transition ongoing now between countries that are shifting from primarily what has been an infectious dermatoses state to more communicable and more non-communicable diseases and chronic diseases over time. But we still know that a large portion of the world is suffering with major infectious conditions such as dermatophytes, which we were just hearing about drug-resistant dermatophytes earlier today. So I know that Claire did a beautiful job sharing with us the advancements with the World Health Assembly resolution. What I wanted to share is this new pathway, and we really try to, my favorite phrase is yes and. We need to do all the things. So it's not just having the Worry Task Force for the World Health Assembly resolution, it's not just having the ILDS and what we're doing there, but it's also how can we amplify the voice and amplify the voices of those around us. And so working with other journals and other medical journals can be a great way of doing this. So a Lancet Commission is something that really elevates a particular topic or area. It takes several years, and at the end of that period, there's basically a large dossier that's published that focuses on the state of health, but also sets very high targets. So you see, if you look at other Lancet Commissions, I would highly recommend the Lancet Commission on Global Surgery as a great example. You'll see there that they'll set a target for either elimination or how we can improve the status quo. And we're very excited to be able to do this now for skin. So here are some great examples from global surgery, from looking at health systems and food, to looking at adolescents. So there have been a lot of Lancet Commissions. We know over the last 20 years, at least 100. And as I mentioned, we've never had one on skin. So I feel like we are a very neglected organ. And this is our moment really to be part of this general medical audience. So I'm delighted that we've kicked this off in China, in Beijing, back in November of 2025. And we've just published the kickoff notice in the Lancet about 2 weeks ago. And this will now proceed over the next 2 or so years. So the idea is to really deliver a comprehensive global report, to look at policy toolkits for what can we prepare for different governments, and really to think about how we can also amplify patient voices in our work. So just to be brief, there are currently 4 case studies, and we're going to be adding a 5th on stigma. The way that Lancet Commissions work is that you don't necessarily talk about the whole world, because obviously you can't cover the entire world in one of these commissions. What you do are particular cases that are kind of scenarios, and you explore those and see how that can provide implications for the rest of the world. So the 4, and then we'll be moving to 5 that we'll be sharing. One is a focus on this transition that I mentioned, this epidemiologic transition to non-communicable diseases, highlighting work in China. The second will be, you've heard about the Skin Observatory Study, which is a collaboration between ILDS and L'Oreal Dermatologic Beauty and the WHO, which is our Skin Observatory Study. They'll be looking at workforce shortages and what we can do around the world. The third will be focused on skin-neglected tropical diseases, led by Niraj Parajuli from Nepal. The fourth will be early diagnosis of melanoma and other skin cancers using AI, and Tori Marr, who was here earlier but had to leave for another talk, is leading that case. So this is the publication from just a few weeks ago. It's a very short read. I think it's about maybe 750 words, 1,000 words, so super fast read. I encourage you to take a look at it. And I just wanted to share this with this community here, because I think it's very exciting when skin health can be recognized in different ways on the agenda, whether it's at the WHO or whether it's at an organization like the Lancet, who really has the ability to amplify our voice. I mentioned the Skin Observatory, and I know that Claire did a great job explaining this earlier. We have collected data from 158 countries, which encompasses 97% of the global population. Our first paper is currently under review, and we're really excited that alongside this paper, we will eventually be uploading this Data Explorer, which will be really interesting, that you'll be able to go in, explore different regions of the world, explore our data. You'll be able to download our charts as PDFs or as PowerPoint slides that you can incorporate. And so we're really excited about the implications that we're really sharing the data with the world. So more on that as it becomes available. And I think, a huge thank you to our commissioners from the Lancet from around the world. And you'll see many of our Chinese colleagues on here, which is really exciting, a new direction of collaboration for us. And we're co-chairing it myself, Sinead Langan from the UK, and Xiang Chen from China. And I want to say a huge thank you to my whole team for all of their work. You've heard a lot about our work sprinkled in different things, and a big thank you particularly. My team is here if you guys want to stand up and just wave. Please, thank you. Right there. Thank you, guys. And I circled Parisa because thank you for helping me with my slides. So with that, I will pass it over to Carrie to take it away. Thank you all.
Well, I want to thank all of that panel of speakers.